Next speaker is Dr. Krishna Chaithanya B. He is Associate Professor in Anesthesiology, Maharaja Institute of Medical Sciences, Nilimarla. His areas of interest are opioid analgesia, difficult airway management, intraoperative awareness prevention. He is a winner of second best research paper and second runner-up in RACE 2015, and is given gold medal for district administration of Vijayanagram for COVID-19 pandemic prevention. And next is he has done scientific talks of opioid-free anesthesia, physiology of aging, and newer drug delivery system in previous conferences. Welcome you, sir, and over to you.
Thank you for having me here, sir. Thank you for your kind words of introduction. Good afternoon, everyone. So it's indeed an honor to be standing right in front of you. So today's topic is postoperative pulmonary complications. Won't take much of your time. So greetings from my place of work, which is MIMS College in Vijayanagram. So let's approach this topic by knowing the definitions and grading, the risk factors, complications in both non-thoracic and thoracic surgeries, and how we reduce or prevent them. So to arrive at a definition, I used these two studies and came up with a wonderful compilation of the definition. First of all, the postoperative pulmonary complications are respiratory complications occurring within 48 to 72 hours of the surgery, and those which adversely influence clinical course, and those which produce identifiable disease or dysfunction that is clinically significant. So basically, grading is simple. Grade 1, they don't require any pharmacological treatment or surgical intervention. Grade 2 require pharmacological treatment like nebulization or pneumonia requiring antibiotics. Grade 3 requires surgical, endoscopic or radiological intervention. And grade 4 is life-threatening conditions. So how common are postoperative complications? Of course, they are very, very common. This is a simple study from Anesthesia Journal which shows that even in emergency laparotomy surgeries, besides infective complications, pulmonary complications are the next serious complications. So 5 to 10% of patients undergoing non-thoracic surgeries and 15 to 20% of patients undergoing thoracic surgeries face pulmonary complications postoperatively. The risk factors are quite evident, like the increased age, positive cough test, COPD, history of OSA, poor general health, obesity, duration, type of surgery, site of surgery, and even blood transfusions and even nasogastric tube can increase the chance of post-op pulmonary complications. So the risk reduction strategies can be planned from preoperative period, and so is our surgical and anesthetic technique. So let's dive into the topic proper. First one is the atelectasis. We all know three types. One is compressive, absorptive, and the next one is surfactant loss. Compressive, we all know because of the upper abdominal surgeries, the pain prevents us from breathing properly, causing basal atelectasis. Absorptive atelectasis, this concept is very interesting because post-operatively we tend to use mostly 100% oxygen and do suction. But I advise it's not proper because of the loss of oxygen quickly. Because of 100% oxygen, if you try to suction it, the quick loss of oxygen from the alveoli cause sudden collapse, and which increase the chance of atelectasis. So what we follow is something called vital capacity maneuver, where we reduce FiO2 to just less than 60% to maintain proper SpO2, and using CPAP and PEEP in case of obese patients. So this loss of surfactant can occur perioperatively also. So all these can lead to reduced compliance and impaired regional ventilation and retained airway secretions. And patient can be asymptomatic or hypoxemic, and most often it occurs in the second to fourth to fifth post-operative night. So prevention is by good analgesia, incentive spirometry, and deep breathing exercises, early mobilization. And treatment of the atelectasis depends on the secretions. Fewer secretions might need simple oxygen CPAP therapy, but abundant secretions will require suctioning plus chest physiotherapy and even bronchoscopy if necessary. Other complications is bronchospasm, which is due to aspiration or histamine release due to drugs, or when the dilatory effects of the inhalation agents reduce. It manifests as dyspnea, chest pain, wheezing, tightness, increased expiratory time, hypercapnia. We should treat the underlying cause, and remember that beta-2 agonists inhaled route are the first line, anticholinergic like ipratropium can be added, and glucocorticoids are the next line. However, remember that aminophylline like methylxanthines have more side effects compared to the benefits, so only the last resort. So next complication, pneumonia, where the atelectatic area provides the nidus for infections. Subglottic secretions also can enter the trachea and cause tracheobronchitis and can lead to VAP-like conditions. Remember that nasogastric tube, we always in an emergency or in normal elective surgeries also, we keep the nasogastric tube and try to intubate the patient while it's there. But remember that nasogastric tube is preventing the proper closure of gastroesophageal sphincter. So pull the nasogastric tube above the esophageal sphincter before intubating, and later on you can pull it inwards. High volume, low pressure cuffs we all commonly use, but remember that the channels, they provide conduits for infectious material to enter the trachea too. So most common organisms are Staph aureus, Haemophilus influenza in trauma patients, and Acinetobacter as in mechanical ventilated patients. Diagnosis is simple: fever, purulent sputum, leukocytosis. In fact, patient can be diagnosed using the same criteria as VAP. So it occurs within five postoperative days. Fever, leukocytosis, increased secretions are seen. So prevention is simple, like limiting the duration of surgery less than 2 hours. In fact, we all request the surgeon to make it fast. Obviously, it has a very good reason. Decrease unnecessary sedations, avoid long-acting neuromuscular blocking agents, and avoid nasogastric tube whenever possible. Treatment is collection analysis of the sputum and proper antibiotic therapy. So gram-negative organisms can require pipzomyropinum, gram-positive requires vancomycin penicillins. Neurosurgical patients are infected by Staph aureus, and depending on the organism, we can go for antibiotic cover. Next complication is acute upper airway obstruction, which can occur immediately postoperatively, manifests as stridor, aphonia, and dyspnea. Obviously, the clinician who is well experienced in managing the airway should only take over the case and immediately intubate, and even if necessary, provide fiber optic intubation if necessary. Exacerbation of OSA can occur 24 to 48 hours postoperatively. The exacerbating factors are anesthetic agents as well as the position. So reduce the unnecessary sedations, reduce the opioid doses, go for multimodal analgesic therapy, and don't forget to elevate the head end of the bed. Pleural effusions, mostly they are small and resolve spontaneously, but we need not worry much. Chemical pneumonitis is due to aspiration of acid gastric contents, which manifests as abrupt onset dyspnea and tachycardia and fever. So this is a study which was conducted, which was a retrospective study which was conducted by Warner in 172,000 patients, and he noticed that aspiration was quite common as 1 in every 3,000 patients, and mortality was 1 in 70,000 patients, which is not a small figure to neglect. Most often they occur at the time of extubation laryngoscopy. So there is no, usually sequelae if there is no cough, wheeze or desaturation. However, some patients can land in bacterial infection and ARDS. So if there is a witnessed signs of aspiration or regurgitation, turn the patient laterally immediately and suction the oropharynx. If you are suspecting aspiration, monitor closely for 24 hours and go for oxygen, NIV and mechanical ventilation. However, studies have shown that there is no role of prophylactic steroids. Pulmonary edema can be cardiogenic or non-cardiogenic. Cardiogenic edema can occur when the fluid retention is greater than 67 ml per kg. Majority require conservative management or NIV or intubation. However, remember that it takes 3 to 12 hours for resolution of the condition. Non-cardiogenic edema, we have, for example, negative pressure pulmonary edema. It can be explained by Muller's reverse Valsalva maneuver, where when the patient tries to breathe in through the closed glottis, there is increased pressure, which increases the right heart pressure and dilatation of pulmonary vascular bed, which pushes the IV fluid into interstitial space. And similarly, hypoxemia can also increase the afterload on the heart and can increase the transcapillary fluid efflux. Risk factors are obviously obesity, short neck, OSA, and previous ENT surgeries. Patient can present with dyspnea, pink frothy sputum, and bilateral chest infiltrates. So always monitor longer, because even if the patient leaves the PSU, he is still at a risk of developing pulmonary edema. Most cases resolve spontaneously. However, few patients require bronchodilators, oxygen, and CPAP if necessary. Coming to the apex predator of all, we have the pulmonary embolism, which is common in post-op orthopedic surgeries and malignancy in obese patients. 3 cardinal manifestations are cardiac arrest, obstructive shock, and persistent hypotension not responding to any form of treatment. Diagnosis perioperatively is very difficult because patient will be on the table or post-operative. We can't even move him in that situation. So transthoracic echo can help us rule out the pulmonary embolism. Patient can require CTPA for confirmation. Management is thrombolysis, surgical embolectomy, and vena cava filters. Next complication is abdominal compartment syndrome, where increased intra-abdominal pressure post-operatively can cause symptomatic organ dysfunction. Like we see, it can affect all the organs. Other complication is tracheal laceration, which occurs mainly during ET tube placement. Sometimes we tend to forcibly push the tube even if the patient is not completely relaxed or not completely sedated. Conservative management can be helpful if the tears are just less than 2 centimeters. However, larger tears will require sternotomy. Keep mindful. Respiratory failure can occur due to pulmonary edema, atelectasis, pneumonia, aspiration, airway obstruction. Respiratory failure requiring emergency intubation, remember, has a high 30-day mortality. Management is always remember in the post-op period, patient who has undergone general anesthesia, long surgery, always try to give a little oxygen to the patient because it's always helpful and can prevent the post-op respiratory failure. HFNC, it's a wonderful equipment we have now, but it might not be available in all centers. So always keep in mind patient might require NIV. Acute lung injury can occur post-operatively and can reduce lung complaints. Primary lung injury can occur immediate post-op due to systemic inflammatory response. Secondary lung injury can occur 3 to 12 days post-op due to other complications like sepsis, pulmonary embolism, and aspiration. This is a new score which is called lung injury prediction score, which helps us to preoperatively stratify the patient into low, intermediate, and high risk. Score greater than 3.5 indicates high risk patient. We all know this transfusion-associated lung injury can occur within 6 hours of transfusion due to any blood product. Two types, mostly due to donors HLA which reacts against recipients' leukocytes, or donors neutrophils which are already activated previously can stay in the lungs and they are waiting for the chance. Whenever we transfuse a blood product, the lipid products can activate the neutrophils and cause complement activation, which can cause neutrophil-mediated endothelial damage and capillary leak. We all have faced these complications, COVID-19. So multicentric observational study, this study has shown that complications are more post-operative pulmonary complication in those patients who have surgery and in whom SARS-CoV was detected within 7 days or given more than 30 days post-operatively. So coming to the thoracic surgeries, patients undergoing lung surgeries, we see besides the serious complications, respiratory complications are more. Respiratory failure can occur 24 to 48 hours after surgery. ALA or ARDS can occur most often after right pneumonectomy. Respiratory complications can be very severe that can lead to multi-organ failure and death. Pulmonary edema can occur most commonly in the elderly, particularly after lung surgeries due to re-expansion, due to rapid re-expansion. In fact, it also depends on the duration of collapse and the airway obstruction and also the rate of re-expansion. So avoid aggressive reinflation and avoid hyperinflation of the lungs. Post-pneumonectomy pulmonary edema can occur 12 to 24 hours after surgery due to excessive IV fluids and the inability of the body to drain away the excess fluids. It manifests as progressive dyspnea and hypoxia. Persistent air spaces and air leak can occur in elderly, particularly COPD patients, that too after lung reduction surgery, and that too in the superiorly in the apex regions of the lung, manifests as pain, dyspnea, and hemoptysis and fever. Persistent bubbling in the drain should immediately alert us regarding the chances of persistent air leak. Persistent air leak greater than 7 days can require video-assisted pleurodesis. Management should be targeting opposition of lung layers to prevent to encourage the healing, and also selective bronchial blockade can prevent this complication. Bronchial disruption can occur after major pulmonary resection due to suture slips and impaired wound healing, which is common in the patients who are immunocompromised. So patient presents with sudden breathlessness, air leaks, which manifests as bubbling in the pleural drain. Diagnosis with CT MRI. Mueller and colleagues proposed a mechanism where patient is encouraged to inhale oxygen plus nitrous, and when sampling the pleural gas via the chest tube, rapid increase in nitrous oxide suggests that there is a bronchopleural fistula. Other complication is pneumonia, which occurs in 5 to 10% of patients after lung resection, and organisms are most commonly as staph and Pseudomonas. Air or fluid can be collecting in the pleura as pleural effusion. Chylothorax also can occur, but it is rare. So conservative management can occur, or we can also go for octreotide, which reduces the fat absorption. MPMA occurs in 2% of the thoracic surgery, but it's a serious complications. So patient might require drainage and appropriate antibiotic therapy. Pulmonary torsion is an interesting complication which occurs most commonly in the right lung, that too after lobectomy, because right middle lobe is the most risky part which can undergo torsion because it is free to move. So though dual blood supply is protective, but always keep in mind infarction and gangrene can occur. So patient might need urgent surgical re-exploration, reorienting and stabilizing the lung. Mediastinal shift, we all know, even though the lung tissue has been removed, still during re-expansion or due to accumulation of air or fluid, that mediastinal contents can be pushed to the other side by the operated side. Post-pneumonectomy syndrome includes persistent mediastinal shift as well as bronchial obstruction. It most commonly occurs on the right side. This is an interesting complication. You all know, diaphragmatic palsy, where there is damage to the phrenic, vagal, or recurrent laryngeal nerve. We can see as in a fluoroscopy as the sniff test, where there is a paradoxical elevation of the paralyzed side of the diaphragm. Complications following cardiac surgery, where preoperative pulmonary complications also can contribute to increased postoperative pulmonary complications, like in smoking, COPD patients. And also know in Euroscore 2, which predicts postoperative mortality after 30 days after cardiac surgeries, also includes chronic lung disease as a risk factor. COPD increased risk of death by 20%, and smoking, pulmonary hypertension, obstructive sleep apnea, as well as cardiopulmonary bypass also increase postoperative pulmonary complications after cardiac surgery. Similarly, increased age, diaphragmatic atrophy due to prolonged ventilation, and swallowing disorders all can cause post-op pulmonary complications. So hemothorax can occur when adequate drainage after cardiac surgery is not obtained. Ultrasonographic sensitivity is more compared to chest X-ray. Atelectasis can occur due to particularly artificial ventilation, manual compression during surgery, and lung collapse, which is done during cardiopulmonary bypass. Post-pericardiotomy syndrome manifests as fever, pleuritic chest pain, and friction rub. It is an inflammatory process which occurs 5 days after surgery, can occur up to 3 months. Mild symptoms usually have a good outcome. Chylothorax is a very rare complication. It's due to lesions of the thoracic duct. Drainage of greater than 1 liter of milky fluid with high fatty content is the diagnostic criteria. Subcutaneous octreotide, as I already told, acts on vascular somatostatin receptors, which reduces intestinal blood flow and reduces lymphatic excretion. Pneumothorax can occur due to central venous cannulation, direct lung injury during surgery, and mechanical ventilation. Clinical features are subcutaneous or interstitial emphysema, pneumopericardium, pneumomediastinum. Ultrasonography is accurate diagnostic tool, like we all see. Beat sign is known, but if it's a barcode sign, it suggests pneumothorax. Management is with needle aspiration or catheter drainage or VATS or fluoridesis. Pulmonary congestion or edema can occur with minor or major complications in every post-op patients. Patients can require PEEP and non-invasive ventilation or even inotrope support or even ECMO or LVAD. ARDS can occur in 0.4 to 4% of patients due to physical compression of lungs, blood transfusion, CPB, or discontinuation of ventilation. Treatment is treated like any ARDS patients. So pulmonary embolism can occur in 1 to 4% of deaths. Like I already told you, it looks like the apex predator of all the complications. Always consider this complication in sudden unexplained collapse. Major risk factors is DVT. Echocardiograph shows right ventricular dilatation, tricuspid regurgitation, and paradoxical movement of right ventricular septum. Prophylactically, Europeans suggest the use of low molecular weight heparin, and Americans suggest the use of stockings for the patient. Phrenic nerve palsy can occur due to phrenic nerve damage when cold saline is used for myocardial preservation or ice flush is used during cardiac transplantation. Bilateral phrenic nerve palsy is potentially fatal. So can this postoperative pulmonary complications be prevented by obviously practicing proper strategies like going for postoperative ventilation, but carefully to decrease the ventilated distress, as well as avoiding excess PEEP, only practicing small tidal volumes and appropriate PEEP. Enhanced recovery should be encouraged by removing unnecessary sedations, avoiding long-acting neuromuscular blockers. Cardiopulmonary bypass can be modified by practicing heparin-coated circuits and miniaturized systems for cardiopulmonary bypass. Lung protection during cardiopulmonary bypass can be by cardioplegic solutions to lung and leukocyte depletion. Off-pump has shown no of any benefit compared to on-pump CPB. Ultrafiltration, post-op analgesia, and interestingly, steroids can also reduce the incidence of post-op pulmonary complications. Blood transfusion should be done judiciously. Physiotherapy, which can start from pre-op period, can help us reduce the complications. And these strategies like avoiding alcohol, improving nutritional status, preoperative inspirative muscle training, use of bronchodilators, and removing airway secretions at proper time also reduces lung injury chances. So at each step, we should have the proper planning to reduce the postoperative pulmonary complications. So to summarize, they are the major postoperative pulmonary complications are the major cause of morbidity and mortality and prolonged hospital stay. They are more common and serious than we think. Bronchospasm patients require beta-2 agonists as the first line. So proper anesthetic planning preoperatively can reduce the incidence of post-op pulmonary complications. Limiting the duration of surgery to less than 2 hours is always suggested. Use of tapered cuff polyurethane tubes reduces the chance of aspiration, and systematically applying bundles of measures at each stage of surgical process reduces the complications. Early interventions in stepwise manner minimize the pulmonary complications. Thank you.